This is from a much larger presentation, but I wanted to provide some insight on the considerations for delivery of AI-driven clinical decision support. So let's dig into it here. 4.5 trillion. That's the size of the US healthcare market. It has an annual growth rate of 4.1%, or $185 billion annually, and accounts for 17.3% of GDP. 400,000. That's the number of hospitalizations where there was preventable harm done to a patient. Preventable harm. Out of that preventable harm, 100,000 patients died. And this includes medical errors such as surgical, diagnostic, medication errors, errors with equipment, and even healthcare technology errors. And I want to point out that any clinical decision support solution should reduce healthcare errors. That technology should not increase healthcare errors. Also, to decrease overhead, hospitals have reduced nursing staff. So a clinical decision support tool helps fill that gap, if built correctly, helps fill that gap for those staffing shortages. $20 billion is the direct cost of hospital errors, and $40 billion is the direct cost of medication errors, both inpatient and outpatient each year. So keep this number in your head, 70%. 70% is the number of errors caused by communication failures. This is what any clinical decision support solutions solve for, is those communication errors. These are errors in communication between clinicians, communication between systems, communication between the entire healthcare infrastructure. 70% of the errors that are caused in the delivery of healthcare are caused by communication failure. This shows the current growth rate of the clinical decision support market, which stands roughly around 8%. This slide provides some of the competitors already in the clinical decision support market. Oracle, Epic, and Meditech, they do have their own clinical decision support tools, but they're also the largest EMR vendors or EHR vendors in the country. Some of the clinical guideline vendors included Wolters Kluwer, Merative, EBSCO, and several others who have solutions that actually integrate with those EHRs. But this will give a little bit of a high-level look at some of the vendors, their offerings, and distributors and some of their end users. This is the top 10 list of the clinical decision support tools that are currently used in the US market. Obviously, Epic, Oracle, Cerner, and Meditech have the bulk of the market. They are by far outperforming. They've also been in the longest. And all the clinical support tools that are currently in the market that are doing well integrate with these solutions. And the more agnostic you can make that integration, the better. So some chief complaints in working with clinical decision support and EHR tools. It's difficult to get a clear picture beyond the clinical parameters. In other words, just beyond the numbers. It's time consuming to aggregate all that data. They're unable to easily tailor care plans for a particular patient, and it's almost impossible for them to stay up to date with real world evidence. Current solutions interrupt their workflow. They're constantly getting alerts for this or for that they have to click that. They just click to close and quite often don't pay attention to. Reading past clinical notes can be time consuming, and quite frankly, the notes can be inconsistent. It's difficult to collaborate and engage with patients. Difficult to share information with peers and receive expert advice on complex cases. There's a lot of physician bias in the treatment of patients. There's sexual orientation bias. There's racial bias. There's bias in gender. There's bias across the entire spectrum of healthcare. There's no way to analyze outcome data from past experience. And there's inconsistencies and incomplete information across all the platforms that they have to use in looking through and treating a patient. Your key stakeholder over all other stakeholders for a clinical decision support tool is the patient. The patient is your primary customer. Secondary to them is the clinician. It has to be a usable workflow. If the nurse or physician or pharmacist can't understand the workflow or isn't getting responses that they need from your artificial intelligence clinical decision support solution, then they won't use it. Your buyers are at the tail end of the primary stakeholders. I know this seems odd, but I don't know how many times I've been in a room and the first thing out of someone's mouth is the venture capitalists want X. Your venture capitalists are not important in this scenario. They're not. They are at the bottom of the list. If you build this to the patient and it solves patient health problems and it helps clinicians treat patients and there are positive outcomes, venture capitalists will make money and they'll be happy. But if you try to build a solution around the business side before you build it around the patient, you will have a failed solution and no one will be happy. So this slide addresses value adds for any clinical decision support solution or the value adds that any CDS solution should have. So for the user, it should provide treatment recommendations based on up-to-date evidence correlated from multiple sources. In addition, there should be transparency to how those decisions are derived, meaning when a treatment option is provided to a clinician as they work with a clinical decision support tool, they need to have the ability to drill into the justification for that treatment option being given to them. Also, the system needs to improve over time, and it needs to provide for changing patient condition at the point of care. So if blood pressure goes up, there should be a change. If it goes down, there should be a change, and those should be immediate. There should be resolution of contradicting or incomplete evidence, and it needs to account for physician biases and variations in care delivered from past intervention. And it needs to inform the physician about key questions and gaps in information that need updated to provide appropriate personalized care. For the buyer, their value adds are improved consistency in care planning, improved benchmarking and tracking of physician performance, time savings while improving patient care, and a reduction in treatment errors that reduces legal risk and reduces the risk of increased costs. Here I look at what AI-driven CDS must not do. The first thing it must not do is hallucinate. It cannot, under any circumstances, hallucinate in production. It can hallucinate in development or QA all at once. But once a solution gets into production, it cannot hallucinate. If it does not or it is not confident of an answer, it needs to fail. In other words, it needs to provide a response that says you will have to look directly at the clinical guidelines or you will have to look through other sources manually. You cannot have a conversational agent or any other type of clinical decision support tool that hallucinates and argues with the clinician. They will stop using it and they will inform everyone in their institution and everyone they know not to use that solution because it won't be able to be trusted. So it cannot hallucinate in production. Also, hallucination harms patients and you just can't do that. It can't interrupt the clinician workflow. It needs to integrate with the EMR or with the EHR. They have so many screens that they pop up late and they look through. There needs to be a way to reduce the number of clicks that they need to go through a system. So the more interactions with a system that can reduce, the better. It can't be passive. It must respond to real-time events and be configured to adjust responses based on changing patient information at the point of care. This is different from providing overall treatment options. This is an understanding of what is changing in the patient and making adjustments based on patient response. And I can discuss further the difference of that. Treatment guidelines cannot at any point, and I cannot stress this enough, ever in any way be from untrusted sources. Guidelines must be clinically reviewed and approved. I have had many discussions over the last year with developers and architects and people trying to get into the clinical decision support business who have said, well, a clinician will know when it's wrong. Not always. Quite often, these tools are utilized greatly by students interns, nursing students, residents, and users new to the healthcare industry because they find it comfortable to use these tools. People have been there for a while. As we all know, sometimes they have trouble adopting new technology. So it's going to be your newer and less experienced individuals who are going to start capitalizing on this tool first. You cannot have a solution that relies on, well, they'll just know if it's wrong. Not only that, no one should ever develop a software and say, well, if it doesn't work, that's okay. That's a bad attitude. But quite often I've seen that a lot recently. Also, it cannot make definitive medical decisions. It needs to provide treatment options. One thing we've looked at over the years is options 1 through 5. And what's great about that is if they always choose option 3, you know that you can reorder and put option 3 at the top. And it also provides feedback if a clinician is choosing an option and you get feedback on what option that they chose. It allows you to adjust your AI, your CDS solution over time to make sure that the most useful option is at the top. It also gives you some research from facility to facility. So if one facility is choosing option 3, another one's choosing option 2, another choosing option 4, and you can look at the outcomes across all those facilities, you can provide feedback on what option is actually the best one to use. And that's extremely powerful. Also, don't eat the elephant. Focus on the most common conditions first. Building for the most obscure disease will only waste your time. Always focus on the 70% rule, and you will have a successful release. So overall, this is what an AI solution should look like in clinical decision support. So at the top, SDH, social determinants of health. We already know that economics determines outcome. People of a higher economic status, people who make more money, who have access to health care, have access to home care, their outcomes are far greater than someone who is struggling economically. That's just a fact. Or don't have access to care, or don't have access to the proper medications. They're going to struggle with their outcomes. And that feeds into the types of decisions that clinicians need to make in ensuring a good outcome for the patient. Obviously, clinical guidelines, insurance information. What are the formularies? What are the drugs that a patient can actually be prescribed? Patient condition, patient history, which comes out of the EHR. Medication guidelines, clinical checklists, the always do's, never do's that are in ERs across the country when patients come in with a heart attack or stroke or other conditions that are critical and need to be dealt with. All those can be fed into a clinical decision support tool to provide a treatment option. Another value is making sure that your CDS tool is integrated with the EHR. Cerner, Meditech, and Epic all have mechanisms for third parties to integrate with their solutions. A clinician probably will not use your solution no matter how good it is if it's a standalone solution, especially at the point of care. Also, any solution, I've got a little loop down here on the bottom right. Any solution should have a learning loop. So you should have a clinical review of anything that comes out of your system and to understand how the clinician has used the system. It needs to understand what worked, what didn't work. And that needs to be fed into the updated training and pushed back into the AI solution so it learns over time. For the actual learning of the solution, I touched on this earlier, but for the learning of the solution, that needs to happen behind the scenes. It can't happen in real time. For the solution to gain knowledge and to understand feedback, it needs to happen behind the scenes in development. If it's trying to teach itself while it's providing treatment for patients, then there's too many scenarios where it could hallucinate and provide erroneous information to the clinician. And that needs to be avoided at all times. Now, can it change based on Can it change its responses based on patient condition? Absolutely. My patient is passed out. I need to do something. Or my patient's awake. I need to do something different. Their glucose is high. Their glucose is low. Their blood pressure is high. Their blood pressure is low. Those things need to change in real time. But understanding how to provide treatment, those high functioning or higher risk conversations and learning scenarios need to happen behind the scenes. So this kind of shows a more simplified version of the learning loop. So at the top I have my patient, and then the EHR. EHR goes into the AI. The AI provides a treatment option that's fed back into the EHR, and then changes are made to the patient. And it's just a continuous loop of information that travels through all systems. So what I wanted to do, again, this is from a much larger presentation, but I wanted to provide some examples of supervised learning models. And one of the things I'm going to point out here, you can look at this on your own if you want to backtrack through this presentation. But there's a lot of similarities in outcome and accuracy between the supervised and unsupervised, which is interesting. I think both for heart disease prediction, they're both at like 88%. And quite frankly, supervised models and unsupervised models, they have different strengths and different weaknesses. And as you're evaluating what to use while you're building your CDS solution, you need to understand what those strengths and weaknesses are. Just like you need to understand the strengths and weaknesses if you're going to use a Google solution in your development, if you're going to build your own, or if you're going to use ChatGPT, if you're going to use Google, or if you're going to use a Watson. Watson, for example, has a proven track record of developing solutions in healthcare and in finance, where the content needs to be solid and where the answers need to be solid. They have a proven track record, and the others are just coming on to the stage. They have made it into the news, but there are other solutions that have been out there longer and just don't have as good a marketing, quite frankly, as the other two. Here's some examples of the unsupervised learning models. And I want to provide some insights into some of the learning models here. Unsupervised learning does accelerate learning, but it does present challenges. Relying solely on unsupervised learning methods has shown to be prone to hallucination. Also, unsupervised learning should be limited to specific problem scenarios where increased oversight can be employed later to ensure accuracy. So if you're looking at a sepsis, or you're looking at, every clinician will tell you how to treat high blood pressure they know. If you're looking at insights on diabetes or insights on a particular condition, and you need to provide better options based on those conditions, you can run unsupervised learning to provide prompts and outputs for that information. But it needs to be checked at the other end. There needs to be a clinical stopgap before that goes out live. Supervised learning does have greater overhead, and this is where the majority of the expense is going to come in for any type of clinical decision support solution, but it's required to ensure clinical accuracy and responses. Without it, you don't have a solution. You also need a method for immediate removal of anomalous responses. Immediate removal. I was working with a development organization. Their ramp up for putting changes out was 6 weeks. That can't happen. You cannot have a 6-week turnaround time in updating a solution. You either need to immediately go to the previous version, or you need to have a way to update and get changes out immediately. At the very least within 24 hours. So be mindful. Treatment options over decisions. The reason is because if you're starting to provide a decision on treatment, you become a medical device, and the FDA is going to want further oversight into what you're building. Also, it provides greater legal risk. If you're providing a list of treatment options, then the clinician has to choose on what option is best for the patient. Also, and the lawyer gave me this information in building my first solution, was we were having a lot of problems with letting legal understand what our tool was and how it worked. And she said, just tell them it's LexisNexis for healthcare. And they will understand the concept of that, because LexisNexis provides a lot of legal background. It doesn't provide legal decisions, it provides support for legal decisions. And that's what you want, is support for healthcare decisions. You don't want to provide healthcare decisions. You want to provide options. There might be some argument out there for that, but you'll end up with a lot more money invested if you're going to be saying this is the exact way to treat a patient. Training advantages. Decisions don't lend to training, but options do. For example, if you provide a list of 5 options based on the available medical information, and your clinicians are always choosing number 4, then you know number 4 needs to be at the top. Also, as I said earlier, if you have a hospital choosing number 1, one choosing number 3, one choosing number 5, and you can see the outcomes in all facilities and understand that, oh, this one's always choosing number 3, and 3 is always has the best outcomes. That's information that you can inform throughout the system to all your users and say, yeah, we understand you're choosing number 5, but guess what? Number 3's been working better for everyone, and we've put that at the top. Learning happens in development, never in production. Your system cannot learn in production. If it does, if it starts learning, it can make decisions in production based on patient condition, but it cannot, or change its options based on patient condition, but it cannot learn in production. It'll open itself up to hallucination and provide erroneous results, and you need to have strict control over that before it goes into production. At every stage of learning, you need to have clinician sign off. Every stage of learning, clinician sign off. If you do not, the first thing out of the mouths, if you're not using curated clinical guidelines and the clinicians are not involved, the very first question that you're going to get from your potential customer is, so who chose these guidelines? What are their credentials? What is their field of healthcare? And if you say it's our developers, you're not going to sell your solution, because they want to know the credentials of the person who wrote the guideline, the credentials of the person who chose to put the guideline in the solution, and their selection criteria for putting that guideline in the solution. And that is all required from a clinician. You need to have curated pharmaceutical and clinical guidelines. I've already spoken to. It needs to have agnostic EHR to integration. It can't be specific to one EHR. The more agnostic you can get, the better. Now, Epic Orchard, they have their own way of integration, as well as Cerner has their own integration method. In fact, Cerner is currently trying to do improvements on theirs, and Meditech has their own. But as much as you can, those APIs that plug in there need to be very agnostic and work with any solution. When you're considering how to construct your EHR, your clinical decision support solution, buy over build, buy versus build, and then partner versus buy. In other words, buy over build and partner over buy. It's almost always cheaper to buy. If there is something out there you can buy, like clinical guidelines, which there are a number of vendors out there, Meritive, Wolters Kluwer, EBSCO, and many others who can provide clinical guidelines in building a solution. Also, deep data content. There are several vendors who provide deep data content. I think Meritive now owns MarketScan, which was once owned by IBM. And then there's Cotiviti, who has a deep data lake that they sell their information, which tracks 40% of the patients in the U.S. And it can provide deep information about historical patient data. But anytime that you can buy, that beats build. And then anytime you can partner versus buy. I worked on a solution where the development team was a strict 10% gross of the sale of the solution. So there needed to be a large influx of team members, and there wasn't the money to build the solution. So we partnered with a third party to build the solution and provided them a 10% revenue share. And all they did was provide the engineering staff. And that is a great way to accelerate development of a solution. And clinicians must be able to drill into the decision path. All right, so I hope you found that all helpful. Thank you for your time. And if you have any questions, please reach out. Or if you don't agree with something I said, I'd love to have the discussion. I'd love to hear opinions on this presentation. Again, this was from a much larger presentation where I get in more detail on how to build a solution, kind of how to plan and how to build the strategy for creating a larger solution, as well as strategies for generating income out of APIs that are built when you're creating your solution, and several other factors that need to be considered in building a clinical decision support solution, and then how to work with the market and work with other people. But anyway, again, if you have any questions, please let me know, and hopefully you find this helpful. Thanks. Have a good day.